Okay, hi. Thank you everyone for joining. We are just here at the top of the hour. Appreciate everyone being on today. We have a great content, fully packed agenda, so we're going to hop right into it. I'm sure we are coming off the heels of some people's summer vacations. We're probably it's the standing in the way of some other people's summer vacations getting started. So wherever you're at, we do appreciate you being here today. We've done, I think, in the ballpark of 15 webinars around the accelerate member engagement work that Clarity has been taking on over the past few years. Today's going to feel a little bit different. We're going to dive deeper into taking a step back and looking at the aggregate of all of the work that really our clients on the phone, all of you, and we have collaborated on together. What are we starting to see in terms of the value creation opportunity? What are we starting to see in terms of the insights that are being made? And how can this really fuel us as we look towards an open enrollment season that's a few months down the line to carry some of that really positive energy into some of the opportunities that we know we've got today? So we're going to have a little bit at the upfront here, just talking about, sort of setting the stage on the state of the industry, accelerate member engagement in general, and then go into some of those case studies. For those of you that haven't joined one of our webinars today, my name is Drew Corbett. I'm the Vice President of Product Innovation at Clarity. I joined just shy of 3 years ago, and really coming from a background specifically on the payer and provider strategy side, with a huge bent towards member engagement. So about 15 years in healthcare strategy, about 12, and I should probably update the slide to another year here of member engagement experience specifically. So a few of the places I've been, but that helps you understand sort of where I've been and maybe give some context as to where we're headed here. This is where we kind of wanted to start. Before we look at just the agenda for the day, I wanted to give a look back and sort of an at a glance. So as I mentioned, the real shift towards driving engagement through the correspondence that Clarity has been delivering for health plans for nearly 20 years, that's been about a 3-year journey for us. And we have, alongside our clients, worked on dozens of campaigns to help drive engagement in critical healthcare actions. We've done this across Medicare, Medicaid, commercial lines of business, individual exchanges, and so on. So really the core offering is meant to be for the member, not specific to a line of business. And that's ultimately turned into, we are just shy of 1 million member actions taken through this program, and something we're tremendously proud of. And if we look at last year was a lot more than the year prior, so we're picking up steam. More and more of our clients are really leaning into our ability to support engagement work within the fold of correspondence, and we're starting to hit some real numbers with that. The focus of this, though, is really about connecting members to key actions or key benefits that are a part of their plans. And whether that is an app or a portal that connects them to any number of great tools, or if it's something more specific, like getting Medicare members immediately involved via welcome calls and nudging those calls to happen. Mail order pharmacy is a place that we're going to spend a lot of time talking today, especially as it pertains in the Medicare population 2-star ratings. So all of those are, I think, really interesting. Where we're going to spend a lot of time today, though, is also looking at the aggregate. The more that we've looked at sort of the compendium of all this work together, the more we see that we are generating huge amounts of data. And these data sets are ones that plans can start to use from a marketing analytics perspective. Are we using everything that we're sending to become more sophisticated in each year of driving engagement? That's where kind of the lights and bells and whistles are going on the Clarity side, and where we're really excited to show what that can do for all of you that work with us. So again, I mentioned our agenda. We're going to talk quickly, just set the scene on state of the industry, kind of what is our why, and that relates to both the challenges and the blockers, the headwinds associated with driving engagement, which I know we're all intimately familiar with. A brief look at sort of why this matters economically to our organization, so some of the economic pressures that are out there from CMS and otherwise. And then we're going to talk about what it means to sort of think differently about our opportunity. So for those, again, that are maybe a little bit newer to the Accelerate Member Engagement offering, we're going to spend a short amount of time here and just talk about what do we really mean when we say this. The bulk of where I want to spend time, though, is on these results and case studies. And you'll notice that we're getting a little more data heavy when we have our discussion today. I want to look at specific star ratings. I want to look at specific metrics and specific things that you all, as you're jotting ideas to bring back to your team and your organization, can say, wouldn't it be valuable if we had an insight like this one? Wouldn't it be great if we were making decisions based on this data rather than small focus groups or on gut instinct? And so that's what we're going to spend the most of the time kind of in the numbers today. So let's buckle in and get started then. State of the industry. We all know this. I would guess this is in more conversations at all of your organizations within health plans than I can even imagine. But the persistent over the last, call it 15 years at this point, the persistent trend is we're trying to drive engagement, but there is noise and confusion that for one reason or another is creating a chasm between members and what those members have to access to live at a highest state of health. And so this is a recent 2023 study out of J.D. Power looking specifically at a commercial population and line of business. But I think the extrapolation is pretty easy to sort of extend across membership. Satisfaction is declining. And we're going to see the yield on that in another slide here. But we also see that sicker patients are less likely to proactively receive their care or have that care coordination in place. We know that from an NPS standpoint, and if we're looking at that as kind of a proxy of our ability to retain or potentially lose to attrition some of our members, that NPS is low on a scale of negative 100 to positive 100. The best we're doing is 25. But with new members, we're actually as low as 6. And so we'll come back to those new members and what correspondence can mean to them as one of their sort of inaugural pieces of communication when they're getting started with their plan. Tough numbers, though. And finally, we know that health plans are also investing in huge and very promising digital health tools and technologies. So when we think about chronic condition management, disease management, tools, apps, partners, services, all of those investments are being made, and for good reason. Those are fantastic programs that have the ability to close down gaps of care where patients especially are at their sickest, but the utilization is really low. So again, we have this mountain of opportunity with this almost unknowing or confused audience. And I think our job, and increasingly how Clarity sees its job, is to say we've got an opportunity to sort of smooth out that road between those people and those resources. So why is this so important then? The economic changes are coming and they're applying pressure. So now we're looking at some MA contracts and some of the data on the Medicare side, where I know there's a particular focus from the audience that's here today, but disenrollment is up from 17% in 2021 from 10% up to 21% from 2017 to 2021. And if we then look at the future of where the star rating calculations are actually going, we're going to get a bit of a squeeze from CMS. And there are a couple of specific things I'll speak to, but the broad point is those plans that have been sort of up in that 4 and 5 star level, there are going to be challenges and pressures if those organizations have been sort of sitting at status quo to hold on to those 4 and 5 star ratings. And for those at the 1, 2, and 3 star level, the ceiling is getting harder to break through. And so a couple things that I'll point to on this, as CMS has looked at a 4.37 overall star rating in 2022, there's a calibration to sort of normalize that market where we're not getting too inflated on where those high value dollars from a reimbursement standpoint are going. So a couple of the mechanisms out here, and I'll try not to nerd too much on this. Through COVID, there was something called a better of provision. And this sort of meant that your star rating in, call it 2021, they were allowing you to either take that cut point and measure that a health plan had achieved, or the one from 2019. and saying whichever one you perform better on, that is the one we will account for. And sort of in the, I guess as a disaster provision, in the sort of chaos of COVID, that was sort of an olive branch out to the health plans to say, we're not necessarily going to grade you based on the circumstances today. One other that's really important to look at is the positive outliers are going to be removed. So if a health plan dramatically had a cut point that outperformed to the point that it was a statistical outlier, CMS is actually going to take those outliers away. And so some of the things that were really pulling your star rating up, you're no longer going to get the same level of credit for those. So all of this taken in totality, I think here's the takeaway. If we look just back a year and we retroactively put those measures into place, we've got about 25% of the plans that were operating in that 5-star, 4-star rating would be dropping at least a half a star. So that's going to affect a lot of the plans out there. And it's a time to just say, how are we doing everything that we can to reduce the impact to our plan in particular? So, within what Clarity can control, we really think about how effective communications are central to bracing for that impact. Or the way that we look at it is really raising the ceiling and the expectation of what you can offer to your members, and to the tune of some really important metrics. So we've done a lot of work, some of our previous webinars, which you can find on our website, we've done with our partners at Engages. They provided a lot of this data too. But when we think about just the content of a communication going out to an individual person, feeling respected, feeling appreciated, feeling educated, all of these have a bearing on a member's likelihood to stay with a plan, to advocate for a plan, and ultimately to get deeper into the benefits that are available because they have a stronger affinity to spend time with those benefits. And so missing the mark on those communications has exactly the converse effect. We've got a higher propensity of people leaving the plan. There's a much lower level of advocacy of word of mouth around how people feel about that plan. And we know that this causes things like that attrition that we saw, which has dropped pretty significantly over the last 3 or 4 years. So we really zoom back into how can we do our fair share of helping to make sure that things like star ratings and HEDIS scores and CAP surveys and ultimately member retention are all things that we're doing our best to maintain at a high level for you. Here's my takeaway. When we're talking about members feeling educated or respected or informed, that's going to look like different things to different people. And so if we've been operating from a perspective of everyone gets spoken to with the exact same language, our position is that kind of status quo, that guesswork, that one size fits all, it's not going to do what we need our communications to do to get the most out of them. And it's going to start to get rattled by some of those dynamics that we mentioned. We're not going to cut through the noise, and we might not ultimately do what we need to do in order to maintain sort of our financial position and standing. So as not to be too bleak on this, there are so many tools out there that are sort of at the industry's disposal if we just look around a little bit. And there are some great examples here. We'll talk a lot about our A/B testing, but the industry really can take on these challenges by moving into a test and learn mentality versus a, at worst, check the box mentality, or at best, trying to just ask the question of, well, what's the best practice? And we'll mimic that. The practice to really embrace is constant change, is test and learn, and that helps us to stay away from those sort of miss the mark communications. The example that I'll hone in on here, Netflix cites that they do about 250 A/B tests every single year. So every 2 or 3 days, they are getting data back on what is the most resonant when people are experiencing that platform. 100,000 people per test. And I think it's really notable to look at that sample size because it's something that puts it squarely within reach of organizations that have scale like health plans do. But these tiles where, we're seeing 9 different versions of the Stranger Things logo, those are not, like they talk about marquee banners where it just changes over time. These are actually going to be specific to where if you and I both log into our Netflix account today, we're going to be seeing different ones based on data that Netflix has gathered over its testing, and then mapping to us, which is going to be the most relevant. These things are out there, and that's not to be looked at as, well, net healthcare is so far behind. I think it really should be looked at as these are robust practices that we can now step into and we can learn from. And that's a big part of where Clarity's work with the member engagement side goes. Okay, so how do we fit into this more specifically? I'll go back to that 100,000 number on the Netflix test and sort of echo that the richness of testing is defined by the size of the audience. And that's a place where health plans have an unbelievable strategic advantage over really many industries. And the second, and where Clarity comes into this, is print correspondence, especially in an era where we're increasingly seeing junk and spam to phone calls, to SMS, and to email. Not to say by any means that we shouldn't be endorsing a multimodal strategy where we're touching on each of those. We absolutely should be. But within the spend that we know we're going to be making on correspondence, we've got this window where we're particularly potent in terms of our message reaching and being seen by somebody. So these great open rates from a trusted brand within healthcare, and then the read time sort of ranging depending on if we're seeing, a member guide or an EOB or a welcome letter. We've got real eyeballs. And if I put my marketer hat on, these are rates that I couldn't even dream of, for example, if I was looking at email statistics. So when we look at this footprint, married with what is sort of germane to the nature of print correspondence and how members engage with it, it's a shame if we're not doing everything we can to bring in learnings and data to sample sizes this large. So we'll start at kind of a micro version for those that haven't sort of seen this specifically from Clarity before. Nothing super novel here. We're just talking about that nature of, instead of one version, why don't we send alternative versions and make sure that we're getting the data back to understand if version A has sort of a tapering likelihood to get that member to engage, for example, in a portal followed by a mail order pharmacy program, and if version B was better. I think we'll look even deeper at what the macro is like on this, but it's really digestible when we just think about, picture two of your members and how different their lives and backgrounds, geolocations, age, gender, all those things might be, and how low-hanging the fruit is to just understand even basic baseline things like this. And if in the aggregate, we're seeing that there is a stronger performer, and maybe we harvest that learning in May, June, July timeframe, that gives us a higher likelihood to drive engagement when we do have those large sample sizes that come around the open enrollment timeframe. Our position at Clarity is that it's sort of a new expectation that we would love for our clients to have with us. You can and you should expect this type of insight to come out of everything that we send for you. And the capabilities are there and the data can start to be there too. So we just looked at the micro at an example of a person receiving a communication. But if we zoom back and say, well, what's the impact at a macro level? One way to look at that is just to say, I think we're looking at sign up for in-home assessments here. And if we know that we've got, a nice part of our population, as I kind of move left to right on this slide, 100,000 people have already signed up. But that means in our population of 400,000, we've still got 300K out there that are potentially eligible. If I send two versions of a member guide, and I even have a 1% improvement and just using the data here, which I think is reasonable, 13 versus 14% on that sign-up rate, based on how I present that information to that person, I realize that there's a little bit of an edge in version 1 versus version 2. That could be a couple of thousand people. Now, a couple of thousand people across 400,000 might not sound like a ton, but think about the value of an in-home assessment and all of the things that helps that member connect into that might mitigate future states of declining health. And so if we've talked to plans that have loosely cited that as $300, $350, You might quickly find $1.2 million simply by, I'm being sort of blunt with it, but by changing the image on the cover of that member guide. If that gets someone to flip, and then that first page gets someone to engage, it's a really, really easy way to take something that you were going to spend on and disseminate anyway. But now we get that huge upside with it. So this is kind of what I look at as being, there's a value to a single member signing up for an action. But then in further aggregate, and I'll sort of like walk through this, but it's our introduction into the star rating section of this. There's the opportunity to really lift the star metrics by way of all these individuals getting more and more involved. What we're showing here are a few individual star measures, and the number over on the left in the column labeled correlation, what that's kind of telling us is that if you're likely to do well in one measure, like for example, getting appointments and care quickly, you have a really high likelihood of doing well in another measure, like getting needed care. Now, both of these are contributing to your reimbursement by way of the star measure itself. But this is kind of a fish where the fish are mentality. If we know that we've got a resource that could affect, look at the measures, and it can actually affect two of them with really high correlation, we're now getting a little more sophisticated around what we promote, how we promote it, and who we promote it to. And so this is just kind of a snippet of, we can really be sophisticated without that much work to understand what we're promoting and why we're promoting it, and we can get that sort of outsized value in terms of our star measures. So I know that's a lot, but it is important because it's how our health plans tick, and it's how we take on the biggest challenges that are facing us today. It's something that we want to embrace and step into. And where Clarity is making huge investments is to support your leaning into that and give you the knowledge to make more informed decisions there. If we just say it broadly, I feel like performance managed correspondence is absolutely the way forward. With the fine-tooth comb that marketers look at email correspondence and subject lines and what works and what doesn't, I think we have a huge opportunity to continue to apply the same rigor and the same methods with the same tools over into the print spend and the print paradigm. So that's a lot of information really quick. I promised that we would get into just some of the case studies and the data that Clarity has seen up to this point. So we'll now transition over to looking at some of those specific instances, real data in all of these cases, blinded data in all of these cases, but some specific campaigns and experiments that we've run. And then we'll move into kind of the practice of harvesting this data and how it can work for you in some of your planning discussions. Over time, we've run enough experiments on, in this case, portal registrations, to where we've seen that there really is a significant delta in what the response rate is to correspondence that's driving that action. And so, it's a place I don't think we often consider ourselves competing, is on how easy is it for members to enroll in our portal. But if we start to look at the data, we realize that there is a huge difference in how easy or how proficiently or how, with what incidence members are actually likely to do this. And if we now think about our goals as a health plan, and if those are in some way, shape, or form related to engagement, and I say, well, some plans have 30% registration on their portal coming out of maybe open enrollment or kind of kickoff materials, and other plans have just under 5%, I know that this is an opportunity for me to do performance management. And so it's an easy place to sort of glean into. Do we overall have an easy and concise member experience? Do we likely have a positive brand perception? It's an incredibly helpful baseline. And we're starting to see that there really are sort of top performers, and there are those that have opportunity to do more work. I think the real value, though, every one of these plans that established a baseline, we now have our first data point. And there's nothing more important in a test and learn type of an environment than knowing where you're starting. And so whether you're, a 4.9% on that registration rate, or you're 10.5%, we start to sort of zoom in and just say, forget about the other plans out there. This is more about saying, how do we drive that up 2% more when we send our next swath of materials to our commercial members? How do we improve within a particular part of that line of business? And we've got the data to do the comparison now. So what's really interesting to me is when we look at those same health plans that we just looked at their portal registration rates, we have a loose but actually correlative sort of line with star ratings. So the higher a portal registration rate was that Clarity found by way of the AME work we've done, there's a loose correlation even with that small sample size to the star ratings being higher performers. So again, I think we're all looking maybe at star ratings and saying that feels bigger than what's within my control. But when we start to look at the linkages to the correspondence is directly correlated to something like engagement in a CMDM program or engagement in a portal or an app. When we start to see that correlation, I think the idea is we should feel empowered that we can be nudging these things in the right direction, and it's very worth doing so. We'll go a little further on one particular case study. I know a lot of folks who have been on other webinars or had discussions with us before. We've actually talked about this one, which was a group that was trying to push more participation into their mail order pharmacy. And forever, they had used one version of a letter which looked like the one on the left. And the sort of ask to Clarity was, we believe that there might be an opportunity to get more participation just by doing some design work to this letter. But two, we want to understand how resonant this really is with people, and we're not currently tracking the data. We're shotgunning this thing out, and then we're just sort of hoping and trying to understand if that ultimately drove people into this program. We need to take a more refined approach than that. So you'll see we put together an alternative version of the letter, and both of these did drive members. And that's what I think is not to be lost with this. There are, especially as we're going to start talking about the Medicare audience that receive these, there are Medicare members where we've learned that something that is very matter of fact, very direct, and pretty business focused is more commensurate with the expectation that they have for communication from their health plan. Alternatively, we have members, and it probably speaks more into the commercial audience, where we want some of those more promotional feeling elements, like the color, like the QR code, like the iconography. The goal is not to say one is better than the other. The goal is to say, who is each one better for? And in that, we start to drive the overall participation. So this is where we've sort of seen that piece before that I just spoke to on the last slide. Where this has gotten really exciting, though, is we're now a little bit of time out from when we ran that experiment, and we can look in arrears at the STAR data and how it's performed since then. So here's how I'll sort of break this down, if you bear with me. When we think about the STAR measures of medication adherence, so your members that are staying on track and on time with refills and actual taking of medications, we've got a few measures that are out there for cholesterol, for hypertension, and for diabetes. So from a CMS perspective, and by way of that, by a financial perspective, these three things are important. And they're so important, actually, that CMS also triple weights these particular measures in a STAR calculation. If you're doing well at these, you're going to get outsized credit over those that are not doing as well in these measures versus some of the other things that we're graded on. The cut points are razor thin. There are 3 percentage points different between 3-star and 5-star. So moving the needle by even 0.5% this year and 0.5% next year and 0.5% the year after that is going to have a huge, huge financial bearing, as you're seeing in the last bullet here. But moving up to a 4-star is worth in the neighborhood of $352 per member. So I'm now looking at how can we be a little bit better with each passing year, because with cut points that tight, we're going to have a huge impact when we ultimately start to see these members trickle in. So an important analysis that we married with this is that when members, this is an NIH study, when members participate in mail order pharmacies, med adherence improves 3% to 9%, depending on which of those three measures we're looking at. So now we start to put some of these puzzle pieces together. When Clarity worked with this client on their AME campaign, we saw 16% of the Medicare members that we distributed out to ended up joining into that mail order pharmacy program. That turned out to be just a little over 9,700 members. Those 9,700 members are equating to between 3 and 9%, depending on how much adherence was actually utilized from those. But we saw what I think is getting awfully close to a 1% increase of their overall population was now engaged in that program. Over at the right, we're looking at the actual CMS data about the performance of those Medicare contracts. And we saw a 1% improvement for diabetes medication in one contract. We saw 1% for both hypertension and cholesterol in another one of the contracts. The volume that we nudged, or an equivalent volume to what we nudged over to that plan, ended up boosting those measures by a percentage point. If we now extrapolate that to let's test and learn, let's do even better next year, and we're getting that 0.5% or 1% a year, we are truly making hay for the health plan, and we are connecting people to their critical prescription drugs along the way in doing so. It's a really exciting revelation that we've been able to look back and say the volume of people that AME moved had a bearing on an improved STAR cut point measure. So one that I think is really interesting to look at. So I wanted to, now that we've looked at a couple individual specific case studies, I wanted to step back and think more about just the general idea of leveraging data to make informed decisions and where that might be most resonant to some of the planning discussions that you're all having around open enrollment. So this is going to still look at our AME data, but in some more broad topics and categories here. So quick themes before we go into a few of these slides and these categories. Successful communication organizations are always leveraging insights like these to test and learn. And it's less about finding we're a health plan that knows the absolute best letter to send out to our commercial members or our Medicare members. If anyone is resting on those laurels, then we're probably only going to be right for about a year. And then the market's going to move, and what's effective and what's not is going to move, and we're sort of going to get left in the dust. So I think the emphasis is really on that practice of we have this steady hum and this engine of insights that come back to us, so that as we author the new member guides, the new welcome letters, the content on the stickers, on those ID cards, it's always being done with fresh data on what's working and what's not. And finally, jumping in is always the hardest part. Baseline metrics absolutely open the door to start having the discussion, though. I think the biggest advice I could give is do one experiment, do a small one, and sort of lighten the load on yourself from an administrative perspective, but get some type of data back so that you can go from A to B. The hardest thing to do is going from nothing to something. Everything after that gets a little bit easier because you're starting to be informed by the information. Okay, so we've gotten really great insight really across most of our experiments. We're seeing some type of data that allows us to analyze age and gender. And the state of the state is that older members are typically more engaged in the calls to action we've been driving than younger members are. And women are typically more engaged than men are. And so that to me just looks at we've got this imperative to look at our younger members and men and understand, especially in the case that they're only one in the household or they might be the subscriber, but they need to be communicated with differently. And another layer on this, and this comes again from the work that we've done with Engageus, but those younger members, we also know that they have a disproportionate need that they have less experience with. And by extension, they need more help with navigating the healthcare system. So we've got some data around that for those in the 60 plus category, are just more confident managing their care than those under 30. That should be reflected in the way that we're communicating important benefits or available benefits to those two cohorts. One last piece with this, we did have one particular plan where we saw that the more frequently, i.e. if we added more touch points or follow-on communications, we were able to have a greater penetration into men's activity participating in those calls to action. So those multiple touch points can work too. Okay, so insights are only interesting if they start to drive ideas and if they start to drive how you manage in the future differently than you managed in the past. So this is where the brainstorm goes based on some of those analytics that we just talked through, but let's go draft something that is more direct, less emotion-based, and shorter communication, and then carve that off and see how it works versus a control with males. If there's a there, we know that we've now got a new incumbent letter that we're going to send out during that open enrollment period because we're getting X% higher lift. Try those second and third messages for really important calls to action. And here's again where I would invite in, this doesn't have to be singular to print. Part of your multimodal strategy can look at those second and third actions or messages for actions too. And then generally speaking, while what jumped off the page was sort of males and then that delta in the age groups, there's no reason that we shouldn't still be hunting for the other variants that can help us across different demographics. So really different language around the exact same action or the exact same program that we're trying to get a member to be involved in. But if we are leveraging data to understand that for pregnant women, our message looks more like protect yourself and your child. For seniors, maintain your quality of life over the winter season. For healthcare workers, if we know we've got a jumbo out there and we really want to be having a high resonance with that jumbo, then we're looking at, protect yourself and your patients might be a resonant message. Again, none of those are going to be a silver bullet. They're worth testing to understand what's working and how we can start to have a more sophisticated pen in hand when we write going forward. Just a quick hit on this one. We've had so many discussions, especially since COVID, around the utility and the efficacy of QR codes. It's another really interesting place to look at by probably by age, probably by gender, but I think more so by age. The net on this is that across every age category, at least for this plan, and that may be different in your plan, but for this plan, there was always value, at least sliced by age, to adding a QR code to a sticker, to a letter, to a member guide. In some places, that was more pronounced. I think really interestingly, the biggest jump from non-QR to QR happened in the boomer 65 plus age cohort. Whereas millennials, it did have an improved efficacy, more likely to cause action to be taken, but not to the same dramatic degree. So this is one that we looked at with this health plan and effectively said, we probably had a going in assumption about this. And some of those assumptions hold true, but we also learned some things that might help us make different managerial decisions in the future too. I think like the main one that would come to mind for me is, do we want to exclude something that is more tech enabled for a certain population? And the learning here would be not the way that we're measuring it today. Regardless if you're Gen Z up to if you're 65 plus, it is additive to use this QR code to drive action. So that's age and gender, just sort of in a nutshell, some of the learnings. The next one that we've had the opportunity, and of course the data gets really rich here because we've got addresses, of course, by nature of what we're sending. And so location and geography insights can be pretty cool when we start to put a couple of alternative versions out there into the market. What we're looking at here are registration rates based on if a sticker was included in a package versus if in the control there was no sticker included. I think the net takeaway here is pretty clear of stickers as we've been groomed to respond to them from the financial industry. They do work, but that's sort of the answer to the question that's a little bit uninteresting if we're in a test and learn kind of a headspace. I really look at where some of the biggest gaps are and where some of the smallest gaps are. So if we orient our attention up to the top right graph and where some of the stars are above the bars there, we're seeing that there is a huge improvement to adding a sticker in Massachusetts, I think in Nevada and in Indiana. Now, if I look over to my home state of Colorado, there really isn't a big bearing. And my takeaway there is we might want to park Nevada, Indiana, and Massachusetts to the side and say we're really comfortable with the performance levels there. We can now start testing something different in those states to see if there's additional opportunity. Colorado, we haven't cracked that nut yet. And maybe that's about the nature of the content on the sticker. Maybe it just doesn't help for whatever reason there, but the data is now talking to us about where the future work to optimize lives. It's really not in Boston, it's in Denver. That's where we want to spend more time to see if within this particular view, we can start better performing. And in some instances, there was an alternative sticker sent out, and we really saw that those perform better than sticker one did at all. So now you're just starting to look at, and I'm referencing those two on the left. We've got something QR code enabled. We've got something that is not QR code enabled, and we're seeing just where those performance variants are. Again, the flip side of the coin is how do we then start to make decisions about, okay, so what do we do next? And that's where the creativity comes into the test and learn kind of a process. I'm really curious now about iconography, about caregivers, in particular, when I look at the zip codes where we've got predominantly non-English speaking households, right? So looking at zip codes, and we'll talk a little bit more about this in a bit, but if I can look at zip codes, I can also cross-reference those with publicly available data sets. I can look at something from the CDC, I can look at something from NIH, and I can understand what sort of the composition of that zip code is. And if I'm really underperforming in that zip code, and that zip code happens to be English as a second language predominantly, I know I've got some of these other tools at my disposal. Let's start to lower the grade reading level if we're going to be in English. Let's include a lot more iconography, or let's also reference that this is content or information that can be shared with a caregiver. That can be a really nice conduit to getting the actual member involved. One other on location and geography that I really key into is looking at the proximity of a member to some of the physical care locations that we're asking them to participate in. So let's say that's for an annual visit. I might want to look and map my my contracts and my network access and say, if I've got members 10 miles or more outside of a network physician that I can point them to, I might want to tune up the volume on the availability of telemedicine for them. I might have an in-home service that's willing to come to them because that's another partner that we've invested in. And these would be people that might really feel like that's a good service for them based on their proximity to accessing a physician. You might also do things like notify if there are extended hours in places where the utilization is really low. Just trying to crack that nut of why are we sort of hurting here? Why are we seeing less engagement? And then throwing hypotheses out by way of our correspondence, and the data is going to tell you what worked. If it was a big spike in telemedicine off of those letters versus the control, then we know that proximity was likely something that was causing their lack of engagement. Response time is another one of the really interesting places that that we've started to look at, kind of one of those critical metrics on the back of the baseball card. So when we're looking at two things that went out, it's about how many overall people registered or participated in that call to action, but also how quickly did they do it. What I'll put in your mind as the reason this is important is the buy it now button on your Amazon account. And we know that the closer we can get to expedient action, the higher likelihood we have of that, in the Amazon case, that consumer, in our case, the member, being engaged in the important activity. So we did an example. Again, we're looking at something that was really testing the efficacy of QR codes and stickers versus not having stickers. But we found an almost 7-day more expedient action was taken when that sticker was included, and in this particular case, when that was a QR coded sticker. That is a metric that matters. I promise it does. And the more we start looking at, if we were at 28 days in last year's enrollment materials, this test showed that we could be at 21 days. That's going to look like a really fruitful January and February for your open enrollment materials if you're starting to leverage this at scale. The last piece that I think we're early days on this, but I wanted to bring social determinants of health into the field of view here, largely because CMS is bringing it into the field of view. Something we didn't touch on with respect to the changing sort of reimbursement environment. As of 2025, we're going to start being graded on our ability to reduce disparities, and we're going to be looking at screening members for these SDOH issues. So there's ample reading that is easily found. This is from health.gov, the example that I've got here. But we know that some of these populations that do have greater health disparities, we know less about them. And that's where it's going to start to sort of double hurt us, is if we don't know and we're being graded on our performance with them. So it becomes a real petri dish of, we have got to start creating experiments to where we're getting more sophisticated than, well, one, we're getting more sophisticated so that we can be effective with the member. Two, we're getting more sophisticated because someone in the market is going to, and we want to be getting those high star ratings so that as attrition naturally happens at the end of a year, we are the de facto go-to plan. We're the plan that has all of the high ratings, and we're starting to get the attrition from other plans that might not have done this homework. Just for an example on how the sort of correspondence can be used in instances like ethnicity in this case, but Engages had done some work that NCQA actually cited, where looking at a call to action being asked and using a couple of methods like specific ethnicity information, leveraging a male voice, both were put together in the form of Hispanics are at a greater risk of, and it went on to discuss whatever ailment or likelihood might be out there. Both of these tactics improve screening rates. If we know that and we're starting to look at these populations and be graded on them, that is unquestionably an edge to get more members involved and an edge to have that higher star rating than some of our competition might not. I mentioned earlier, but this can feel sort of spooky because we don't know this space as well as an industry. We sort of know it as a topic, and as candidly, like, I think it's been more of an idea than it has really been put into practice. But as it starts to be pertinent to STAR measures, look at the opportunity, not just the challenge. The data to be creative is totally on our side with this. I mentioned that census data, vulnerability indices are out there. Just looking at zip codes and starting to marry some of these things can then give us the power to say, we should be writing a different letter or doing a different test in these zip codes than these other ones, because they're fundamentally different audiences with fundamentally different obstacles that they're trying to overcome. We did some light work with this. One of the kind of early tests that we had done where we brought some of that CDC data in and found that when trying to nudge people to use a provider search tool, we did actually have a 13% difference in the utilization if we were looking at zips that were defined by or categorized as impoverished versus if we were looking at outside of poverty zips. So I think that's then where the interesting and creative work goes to say, okay, if we're in an impoverished zip code, what does that look like from a real member's journey? And how can we address what that world looks like to the tune that the provider search tool is now actually beneficial, as opposed to something that might feel heavy or just feels like it gets lost in the noise. Without leveraging data and looking at this, we would continue to sort of pump the messaging with equanimity across both of these zip code cohorts, and we're simply leaving opportunity on the table. We're underperforming in some of those zip codes where we don't have to be once we're made aware of this. So I know that's a lot more data than we usually talk about, but we spend so much time here, and we put the work into kind of pulling all of these insights together in one place, because this is where you can get the most value out of the dollars that you're spending on correspondence. Sort of in summary and related to that, we talked about how the industry is going to insist that we are driving engagement increasingly and to the tune of really big dollars. And so there is a do more with what you have dynamic that I think we're all probably hearing within our organizations. Within our little world of correspondence, this is the opportunity to do that more than we did, say, a year ago, certainly than 5 years ago or 10 years ago. I'll say as an industry, correspondence has really lagged in innovation and capability to carry its fair share of that task. I talked a few times about how email really, since its advent, was performance fueled. We would send something out and we would immediately have the information as to the efficacy of it. And correspondence has lagged there. But the way we're doing our correspondence now is fundamentally changing what the expectation of this line item spend is. It is now fuel for insights, and it is now something that is intentionally driving correspondence. So I think our sort of closing note on this is we really believe that for health plans that are going to be successful, leaning as hard into these practices within your correspondence spend is what the top players will do. They'll be data-centric. They will always be focused on simplifying engagement, and they'll be testing to understand how they're performing there. So with that, we always have sort of the I guess the standing handshake out to any organizations that are kind of new on this or maybe just starting to think about it, as well as those that are already working sort of rigorously with us on this. But if we want to start just with let's make this real. Let's look at some materials. Let's look at what a test construct could look like. You know how to reach us by way of our account managers or just by emailing some of the information we've got here. So that is our content today. I'm actually shocked that we're going to give a few minutes back here, but we really appreciate it. We really appreciate the clients that have gone on this journey with us. We know we're kind of at the beginning of it, but the insights that we're starting to see are really exciting in terms of the value that we can provide. So thanks for joining. Hope everyone's having a great summer, and we will talk to you on our next webinar. Thank you.